Xin chào. Okay, so welcome back. And just this morning, the rest of the morning will be, I'm going to talk a little bit more about heterotaxy, which will emphasize some of the points that we've already been talking about this morning. Then we'll have an opportunity to do some scanning as well. So, what is the definition of heterotaxy? Heterotaxy comes from the Greek. Heteros means variable, and taxis means arrangement. So, a variable arrangement of structures that have right-left asymmetry. This is a nice little picture that appeared in the New York Times, actually, showing some of the abnormalities below the diaphragm and above the diaphragm that we see with heterotaxy. So technically speaking, heterotaxy, when we're talking in terms of the fetal heart and complex congenital heart disease, it's a disordered laterality of the abdominal viscera and the thoracic organs and the heart and the cardiac segments. So there are multiple abnormalities of the structures and how they're arranged with each other. Not just of the heart, but of other structures above and below the diaphragm. And we're talking about organs that have right-left asymmetry. These can develop mirror image anatomy. The right could be looking like the left, and the left could be looking like the right, or somewhere in the middle. It doesn't have to be completely one or the other. So when we talk in terms of subtypes of heterotaxy, like right atrial isomerism, or asplenia, or bilateral left-sidedness, or polysplenia, we try to put patients into one of two different categories. But I honestly think that we should consider heterotaxy as a spectrum of disease, because many patients have features of one or the other. They're not completely heterotaxy, not completely asplenia rather, or polysplenia. They're somewhere in the middle. There's different ways we can use, what kinds of words we can use to describe the two main types. The von Pragues used polysplenia and asplenia, and Bob Anderson has also contributed greatly to this area and talks in terms of bilateral right-sidedness or left-sidedness, or right atrial isomerism or left atrial isomerism. So there are different types of terminology, and there's some differences, technical differences between the two camps. But this is an unusual textbook which actually the von Pragues and the Bob Anderson combined to describe heterotaxy. But I'm going to try to talk to you in terms that, to simplify things, but to talk to you in terms of what I think is clinically useful for your practice, which is the way all today should be, very clinically oriented. So, when I was trained by the von Praguian camp, so I use the term asplenia, but you may choose the term right atrial isomerism or bilateral right-sidedness. We're talking about the same type of abnormalities, but I'll use the term heterotaxy. And I'll also use the term polysplenia, but you can think of it as left atrial isomerism or bilateral left-sidedness. Use whatever description. The words don't matter as much as the actual anatomy, the actual cardiac anatomy, and an understanding of what can go along with cardiac abnormalities in the context of heterotaxy. Turns out that both subtypes, polysplenia and asplenia, commonly associated with functional asplenia and intestinal malrotation. So all of these patients are at risk for some form of immune dysfunction and many of them may require a LADS procedure if they have significant intestinal malrotation. Now in heterotaxy, why it's so important to us to talk about heterotaxy is because about 80% of cases of heterotaxy involve the heart. And commonly we see dextrocardia or mesocardia. We can often have systemic and venous return abnormalities, which is important to recognize because sometimes those are difficult to detect. There can also be inlet and outlet or conotruncal defects as well. So using this diagram by Wyman Lyne in his book again, just because it emphasizes that when we think in terms of heterotaxy, we should use a segmental approach to evaluate a patient with heterotaxy. The segmental approach is the best way to look at the heart when you have a complex heart abnormality, just one segment, one part at a time. And it's similar to how we look at a normal fetal heart, where we look at it one structure or one component at a time, using different views and sweeps. So what are some of the visceral findings below the diaphragm? As I mentioned, splenic abnormalities are very common. They can be absent spleen or multiple spleens. And all of these can have a range of different splenic functions. So many of these patients, asplenics, polysplenics, all these patients with heterotaxy may have a range of splenic function and immune deficiency. So it's useful to be able to counsel and mention that to patients at the time of the prenatal evaluation. There may be a midline liver in asplenia or polysplenia, or in patients with heterotaxy in general. And actually, many of these patients can have biliary atresia, usually patients with polysplenia, or patients who tend to appear like they have polysplenia, that subgroup. But then many of these patients as well have intestinal malrotation, which I don't know if that can be diagnosed prenatally. But certainly it's something we want to counsel patients about when we see them. This is a nice radiograph from Meryl Cohen's article showing several of these abnormalities just in one chest film. You can see the dextrocardia, and the lungs are congested from pulmonary vein abnormalities, often CAPDR. The midline liver is malrotation of the small intestines over here and the large intestine on the left. So many times you can see radiographic abnormalities postnatally. We're going to be talking about echocardiographic findings prenatally. The incidence of heterotaxy, not that common. It's maybe 1 out of 10,000 babies. And it's a male to female ratio of 2 to 1. Like most heart disease, or most disease in general, more common among men than among boys and girls. So it's very, very rare, unusual defect, and it accounts for about 4% of all forms of congenital heart disease. But interestingly, as many of you recognize, when you look in a hospital, many of the patients, pediatric patients in a hospital ward with congenital heart disease have heterotaxy. And that's because these patients have a disproportionate share of morbidity and mortality. They have a very high risk of morbidity and mortality for heterotaxy compared to other forms of more straightforward congenital heart disease. This also is a nice review from a table from Meryl Cohen showing what we tend to see in asplenia and what we tend to see in polysplenia. I just want to emphasize that, again, patients may very well be somewhere in the middle. They may not be straightforward asplenia or polysplenia. But I think it's useful to know what commonly goes together, because when you're evaluating the heart, someone with what seems to be asplenia, you might be thinking about different things than you might be otherwise. I'll just point out a few examples. Interrupted inferior vena cava. That's very uncommon with asplenia, but 80% of patients with polysplenia have it. There can be TPVR in asplenia half the time, but it's very rare, the extracardiac type in polysplenia. Ipsilateral pulmonary veins, where you have the right side of the left side of veins to the left atrium and the right side of veins to the right, is very common in polysplenia, but not so much in asplenia. AV canal, much more common in asplenia, but still half the time in polysplenia. And common atrium, when you have no atrial septum, strongly suggestive of polysplenia. So these are just some sort of the abnormalities. But if you look down on the bottom, heart block and bradycardia is very rare with asplenia. Usually we think about asplenia as much worse than polysplenia, which is generally true, except when it comes down to rhythm abnormalities, because polysplenia has a relatively high incidence of heart block or bradycardia because of an absent sinus node, whereas with asplenia we don't see that. And so when we see patients with what we think may have polysplenia, we can counsel them that this baby may not have bradycardia or heart block at 20 weeks. But over time, this baby is at risk, maybe at risk for the development of bradycardia and heart block, may need a pacemaker after birth. So today I want to talk about the echopyrographic approach to the evaluation of heterotaxy, including some of the ideas we talked about this morning. We will not discuss cath and MRI, although sometimes, for instance, MRI can see structures, CT, MRI, in terms of bronchi and other abnormalities that we cannot see very well by echo. So just to begin with some general concepts, with heterotaxy, we use a segmental approach. We look at we start with the visceral situs below the diaphragm, always starting below the diaphragm if we can, although when we're scanning, sometimes the baby is in a very good position to look at one part of the heart. You could go out of order sometimes, but you just have to remember what you've seen. We start in general with visceral situs, and we look at the cardiac position. In other words, is the heart on the same side as the baby as the stomach? And then we use a segmental approach with sweeps. The sweeps are important to show how one part of the heart is related to the next. It's very important to look in the abdomen. Not so much to see the spleen, although some of you may be able to see a spleen, I cannot, but certainly to look at the stomach, the descending aorta, IVC, and maybe azygos. The IVC can be present but adjacent to the aorta, so more posterior than normal with asplenia. Of course, IVC being interrupted is very suggestive of polysplenia. And the pulmonary veins, very important to look at because often there's abnormalities of pulmonary veins. And sometimes this can be tough to see early on, so it's important always for these patients in particular, when I'm scanning a patient with a complex abnormality, I'd like to have multiple opportunities to evaluate the baby, maybe bring them back every month or two. It depends upon how frequently to bring patients back, depends upon the circumstance and why you're bringing the patient back and how difficult it is for them to come to see you. So here's some examples. Visceral situs on the left is normal stomach. Descending aorta and IVC, sweeping up, and you can see the heart on the left with the apex 45 degrees to the left. Whereas here on the right, you can see the stomach on this side and the heart on the other. In systemic venous return, you can see on the left You see the azygos back here. And the stomach is on this side. Here's the descending aorta, looks like it's on the other side. And now you can see the stomach is on this side, but the heart's over here. And if you put color on the right, the red is the aorta, and the blue is the azygos. So again, you could have an azygos in a normal fetus, but when you have a very prominent azygos, it's often because the IVC is interrupted and the azygos is receiving all that extra flow. So the azygos, just like other aspects of the aortic arches, ductal arches, you can see by transverse imaging and sagittal imaging. They complement each other, and it's worth just practicing so you can do both, because in one baby you may not be able to get good sagittal images, but you can get good transverse. This is a patient with a dilated coronary sinus, and it's dilated because of this structure on the left, which is what? So that's a left-sided superior vena cava, and if you image sagittally from left to right, you'll be able to see the left-sided superior vena cava like this draining into coronary sinus, and many patients will have bilateral SVC, so you keep on going towards the right and you'll see the RSVC. And here on the right, you can see a coronary sinus. It's dilated in the four-chamber view. So from here, you see that from the fourth chamber, then you can turn sagittally and see that the LSVC drains into this. Point of venous return can be very important to pick up because many of these patients with TPVR, total anomalous point of venous return, can have obstruction and require early intervention, can be very sick, and the prognosis can be very, very bad. So it's good to be able to counsel patients. Here on the left, you can see it's this is a TAPVR with a decompressing vein draining down into the liver. Here on the right, you can see, this is also from Meryl Cohen's chapter, you can see supracardiac coming up here. You could see infracardiac here, or you could see coming to the coronary sinus. So I'll show you some examples. This is a nice example using sagittal imaging to show the descending vein. On the left, you can see this descending vein right here. And it obstructs right here at the ductus venosus. And you can see that with the color flow on the right. It's very easy to see, not easy, but if you're thinking about it, you go sagittally and you optimize the image, and you'll be able to see this extra vessel. There should not be an extra vessel going from the chest down to the abdomen with blood flow in that direction. You should just have the aorta going from the chest to the abdomen. Then we think about the atrioventricular connection, and here again you can see the AV canal. And again, the AV valves are at the same level, and there's no crux. The lower part of the atrial septum is gone. During systole, you can see a big common AV canal. And during diastole, they come together at the same level, and the lower part of the atrial septum is deficient. I hope you see that. That's very difficult to see with parallel imaging. It's just an example of the importance of looking perpendicular. If you optimize the image, narrow the sector, get a good window, and then be perpendicular, you can see here, there's no, the crux is absent. This is a true AV canal. The hand rule looks in terms, a lot of patients with heterotaxy will have D-loop ventricles or L-loop ventricles, and once you figure out which ventricle is which, you can apply the hand rule. Sometimes it's hard to tell which ventricle is which, or you may have a single ventricle and you're not sure if it's right ventricle or left. Then in those cases, you cannot apply the hand rule. Then we look at the ventricular arterial connections, and again, in case of heterotaxy often will have multiple cardiac abnormalities, so we try to look at one piece at a time, optimizing the imaging both at every point in time. So this, I meant to mention, so this is the patient with transposition, showed you earlier. Very common to have transposition with heterotaxy, particularly asplenia type. And then outflow tract obstruction with pulmonary stenosis or aortic stenosis can be quite common, particularly pulmonary stenosis can be very common with heterotaxy. Pulmonary stenosis is common in general. Pulmonary valve abnormalities, maybe 10% of congenital heart disease has pulmonary stenosis or even more. And even in heterotaxy, it's pretty common to have pulmonary valve abnormalities. Now, systemic outflow obstruction, aortic stenosis or coarctation, is less common, interestingly, with heterotaxy. But polysplenia type heterotaxy patients can have left-sided obstructions or systemic outflow obstruction, I should say, even hypoplastic left heart. So again, one of the reasons why it's important to know if it tends to be polysplenia or asplenia is if you see a patient with heterotaxy, stomach on one side, the heart on the other, hypoplastic left heart, maybe an interrupted IVC, should be thinking polysplenia type heterotaxy, maybe this patient is at risk not just for splenic abnormalities and intestinal abnormalities, but maybe specifically heart block or bradycardia, so may require a pacemaker. So it's useful to have this background in heterotaxy in terms of counseling. And then the outflow tract obstruction, particularly pulmonary stenosis, can evolve in utero. So at 20 weeks when you make the diagnosis, there may not be much pulmonary stenosis, maybe mild or moderate, and the ductal flow may be normal, right to left. But over time, the pulmonary stenosis can worsen, and you can develop retrograde flow in the ductus, and that's a sign that this baby is probably going to be ductal dependent after birth. So it's important when you're counseling to mention these possibilities and also just to follow so that you make sure you deliver these babies in the right hospital. This is just an example of a baby with polysplenia with atrial bradycardia. There's atrial bradycardia because sometimes babies with polysplenia have no sinus node, so they have an atrial rhythm that's relatively slow, maybe 80, 100 beats per minute. And they also are at risk for developing heart block. So in terms of delivery, if we have a patient, a fetal patient with heterotaxy, if there is significant heart disease, for sure, these babies should deliver, for those pregnancies that are continuing, should deliver at a tertiary care center where there's the expertise to take care of not just the heart, but also if there's the need for GI surgery, for a LADS procedure for intestinal obstruction, or other abnormalities that may go along with heterotaxy, tertiary care center makes sense as the ideal place to deliver some of these patients. And also, of course, like for most patients, it's probably best to deliver at term for obvious reasons. If we're going to require surgery or a pacemaker implantation or a shunt, if there's severe pulmonary stenosis, the bigger the baby, the better. And in general, we like to deliver these babies with heterotaxy via normal spontaneous vaginal delivery, rather than by C-section. Of course, there are exceptions. The babies with obstructed total anomalous point of venous return who may require surgery or cardiac catheterization to stent the ductus venosus soon after birth, those babies should not be electively delivered at 2 in the morning whenever they're ready to come out. They need to be delivered during the day when everyone with the required expertise is available in the hospital. And of course, if there's complete heart block, the babies cannot be adequately monitored for fetal well-being during labor. So those babies probably should be delivered by section as well. And many of them do require implantation of a pacemaker soon after birth. So many patients with heterotaxy actually do quite well. They're not all very bad prognoses. Some of them have very good prognoses, but of course there are elements to some that we can pick up even at 20 weeks in terms of counseling, when we can say this baby's heterotaxy is a very high risk form. What are some of those factors we're looking for? Of course we're looking for single ventricle. Heterotaxy with single ventricle, that's a bad prognostic factor. If you have a single ventricle and you have obstructed total anomalous venous return, most of those patients just a few years ago could not survive anywhere in the world. And now sometimes they are surviving, but those are the exceptions. It's a very poor prognosis to have heterotaxy, single ventricle, total anomalous point of venous return. Patients with heart block and heterotaxy also have a worse prognosis. They need to be paced, many of them, from soon after delivery, and can develop pacemaker-induced cardiomyopathy and other complications related to pacing over time. Some patients have significant valvular regurgitation early on, 18 weeks, 20 weeks, that you can pick up with power flow imaging. Valvular regurgitation early on, second trimester, is not a good sign. It's another negative prognostic factor. Sometimes we can see the foraminal valley is restricted. That can be a tough diagnosis to make sometimes, but if you do see a restricted foraminal valley, those patients are at risk for heart failure or hydrops. Patients, of course, who are hydropic. A hydropic fetus with heterotaxy is a very guarded prognosis and high risk for fetal demise, as well as poor survival after birth. And then, of course, many patients have associated structural abnormalities with heterotaxy, and that can make the prognosis that much more guarded. And some patients with heterotaxy do have aneuploidy. They do have chromosomal abnormalities that can be significant and can impact cognitive function, renal function. So patients with aneuploidy and heterotaxy tend to have a worse prognosis than those patients with normal genotypes. So here's just an example of a patient I saw that was sent to me at a positive screen for Down syndrome and had an AV canal. So you can see the AV canal defect here, but had, as it turns out, a common atrium. And on the right, it's hard to see here, but the left side of veins came over in here, and the right side of veins came over on the right. So that's what we call ipsilateral pulmonary venous return. So it's a baby with an AV canal, common atrium, ipsilateral pulmonary venous return. This baby ended up not having Down syndrome, but had polysplenia. So the counseling was quite different, and the prognosis was different than a baby with trisomy 21. This is how a knowledge of how things tend to go together with polysplenia versus asplenia can be useful. So take-home points from before we do some scanning is that the segmental approach and how you mentally reconstruct the heart. When I do it in my mind, I start thinking with the abdomen, the abdominal viscera, and then the cardiac position. And then I go forward from there. Sorry about that. Pulmonary veins are very important to evaluate with heterotaxy because they're quite common and because they can have an important impact on prognosis in terms of how you counsel and in terms of where you deliver and how you deliver. Conceivably may require C-section. But they may be difficult to detect. Even TPDR may be difficult, even when we do all the kinds of things that we're talking about today in terms of optimizing image. It's maybe easier to evaluate them at 30 weeks. At 30 weeks, maybe 25% of cardiac output goes to the lungs. So keep that in mind in serial evaluation. If you're not sure about the veins at 20 weeks, it'll be easier later on to see. And then there may be progression of disease. There may be obstruction of the pulmonary veins that develops late, obstruction of the foraminal valley that develops later. There can be outflow tract obstruction like pulmonary stenosis that develops late, AV block, or valvular regurgitation or hydrox, all can evolve over time. And the most guarded prognosis with heterotaxy is for single ventricle patients, especially those with heart block or obstructed TPDR. But I also want to emphasize that not every baby follows the rules. There are some babies who do better than we think. That's why when I'm counseling patients, I need to explain all the data, but also tell them that there are, not to always to lose hope. There are patients who do quite good, better than you might think, and it's important to be honest with the family about what we know and what we don't know. So this is one of my patients who comes to my symposium at UCLA every year. He's actually, I think he's 6 years old now, almost 6 years old. We diagnosed him with asplenia, unbalanced AV canal, and double out the right ventricle and obstructed total anomalous pulmonary venous return. So this is a high-risk group, right, with multiple risk factors for a guarded prognosis. But he has done quite well, and he's ready for his Fontan now. And you would see him in a supermarket or playing soccer, and you would never know that he has a heart defect. Now, he is the exception, but we need to be honest with patients that most patients do not do this well, but some can do very well with a lot of support from the family and with good medical team.